All right, so the very last section, and this is connected to issues with the spine. The very last section we're going to talk about is neural tube defects. And these are things that happen when the neural tube fails to close in embryonic development. Remember that one of the risk factors for this is folic acid deficiency. And so we want to promote folic acid supplementation for anyone who could become pregnant. So we're actually going to start at the top and work down. The higher level neural tube defects are pretty tragic and usually don't have very good outcomes. So first we'll talk about cranioskesis. Cranioskesis is when there's a defect in the skull and there's tissue protruding. This is not compatible with life. And if that infant were born alive, they would be given comfort care. With exencephaly, the brain is totally exposed or is extruding through a skull defect. That's not compatible with life. Usually that patient will have a miscarriage before term. Anencephaly. So if an infant with exencephaly, or if a newborn, or not a newborn, if a fetus with exencephaly survives, then during gestation, the brain degenerates into a spongiform mass. And so this is also not compatible with long-term survival. Sometimes these infants will live for a few days after birth. But with in all of these cases, the typical care is going to be comfort care. Encephalocele is when there's a defect in the skull and the brain and meninges herniate through it, but that tissue is contained in a sac. That can be survivable, but those babies usually have severe neurologic defects or deficits. Now, if we move down to the spine, spina bifida is a fissure in the spinal column that leaves the meninges and the spinal cord exposed. Spina bifida occulta means that there's an opening in the spinal column, but there's no herniation of the spinal cord or meninges through that fissure. So usually they don't have any neurologic deficit. Sometimes they will have a dimple or a tuft of hair at the base of the spine. So in our newborn assessment, when we're looking for that dimple or tuft at the sacrum, we want to report that because they need to evaluate and make sure that the cord doesn't need to be protected. Spina bifida cystica is when there is some herniation through that defect in the spine. Meningocele, in meningocele, that sac contains meninges and spinal fluid. Usually there's not a neurologic deficit because the cord itself is not herniated through into the sac. This baby has a risk of infection. And of course, the spinal cord has less protection until it's closed. So this is going to be closed as early as possible. The defect in the spine will be repaired and the sac will be repaired. When actually spinal cord and nerves go into the herniate into that sac with the meninges and spinal fluid, that's called myelomeningocele. And typically, some of that nerve tissue is damaged in that situation, and so they may have some neurologic deficit. There's also a continued risk of infection until it's closed. That risk is greater if the cyst is ruptured. So this would be diagnosed by clinical manifestations if a baby were born and they have a visible protrusion on the spine. That needs to be evaluated immediately. This is often diagnosed now in utero with ultrasound, and the baby would be delivered by C-section with as little disruption of that sac as possible. They would use MRI, ultrasound, and CT to determine the size of the defect in the spine and also how much nerve and spinal cord is in the sac. They also get neurologic exams. We're looking for, do they have movement, do they have muscle tone below the level of that meningocele or myelomeningocele below the level of that cyst. Again, major defects are usually seen on ultrasound prenatally, or they may be diagnosed by chorionic villus sampling. Management, so if they're diagnosed prenatally, they're delivered by C-section in a facility that can care for the infant appropriately. There have been some trials in closing that defect in utero to try to minimize the risk of injury, of cord injury. After birth, early closure of that defect, and we're talking about fixing the spine defect as well as closing that defect in the skin, the earlier the better. So pre-op, we want to really focus on not allowing that sac to rupture. The baby is kept in prone position. The sac is kept covered with more moist, sterile gauze, which requires really frequent changes, and they need to be in a warmer or an incubator to maintain their temperature. Post-op, they're going to have an incision on the back. They need to be maintained in prone position until that is well healed, and we're observing that incision for CSF leakage because the spinal cord is disrupted. So in that post-op period, they can be held upright against the body very carefully. They want to avoid putting pressure or strain on that incision. We need to teach parents how to care for the child before discharge. And then if they have any neurologic deficit, they're going to need long-term management, because once this is closed, it's a spinal cord injury. Until it's closed, we have the risk of infection and the risk of furthering that injury. Once this defect is closed, then it's a spinal cord injury. So there are musculoskeletal complications of spinal cord injury, like clubfoot and other deformities in the lower extremities just because of the lack of mobility, contractures. So we want to do passive range of motion to prevent those. Patients with spinal cord injury can develop kyphosis and scoliosis because the muscles of their back are not fully innervated, and so they may have poor trunk control, so they can develop scoliosis and kyphosis. They may need orthoses, so like some kind of braces or walker or wheelchair for mobility, depending on the level and the extent of the injury. Anytime someone has a spinal cord injury, we have to be careful with positioning and try to prevent skin breakdown. We also have to manage bowel and bladder. And typically, especially in infancy, they're going to have continual urine and feces discharge because it's flaccid paralysis. So they may also develop neurogenic bladder and constipation, and so that's going to need management later on. They may use some intermittent catheterization to manage neurogenic bladder. They may have, they may take meds to increase their bladder storage and improve continence. They may also have surgery for a urinary diversion to make that easier to manage. Dietary management can allow continence for a lot of people with spina bifida. We want to avoid impaction, so plenty of fiber and fluids. They may be on a bowel program that on either every day, every other day, or after so many days without a bowel movement, they have some kind of enema or suppository that they use. But usually there is some kind of a scheduled program for bowel function. They may also have a stoma that is catheterizable and it can be catheterized and irrigated to allow for bowel elimination and maintain continence. So there's some other problems that may happen. Hydrocephalus is pretty common in kids who have spina bifida, and so they may need a VP shunt for that. Any infection is treated very aggressively because they have this opening or they've had surgery on their neurologic system, and so they're at risk for the infection getting there. So that any infection needs to be treated really aggressively. Chiari malformation, which affects the stability of the head and neck, is common. So if they're symptomatic, they may need surgical intervention for that. And latex allergy is very common. So any child with spina bifida, we need to use latex-free materials exclusively from birth. Okay, no latex ever. They were born and they're labeled no latex. Lots and lots of emotional support for the family and then for the child as they grow. For prevention, we want to promote folic acid. The prognosis, kids with spina bifida, their intelligence and their cognitive function is not affected. Cognitive function would be affected if there's intracranial pressure from untreated, so undiagnosed hydrocephalus, or if they have a higher defect that affects the cerebral cortex. But spina bifida does not have an impact on cognitive function. Neurologic function, as far as mobility and sensation, varies a lot. It depends on the level of the lesion. And the survival rate and lifespan are increasing because surgical techniques are getting better and we're getting better at treating the complications. Okay, that's all. This is my last lecture for this semester. So it's the last time you have to watch me.